And there, of course, we will also describe the features of commonly available pumps in the country, which of course belong to mainly two companies, the Roche and Medtronic. Now the targets we have already discussed. Next slide. Okay. It's not moving. Yeah. Now we will be discussing the insulin pump algorithms. We had already looked at the target values which you desire to achieve on pump therapy. Now how do you achieve that, and how do you plan your basal and bolus doses on the pump therapy? Now what you do really is you look at the patient's total insulin dose. For example, let us say somebody took 100 units, then you reduce it by 25%, so the patient should really get 75 units on pump, and you divide that into two parts. Half of the requirement for basal purposes, half of the requirement for meal related or what we call bolus purposes. So about 37.5 units here and 37.5 units here in this instance. So you saw that the initial dose is always based upon patient's previous total daily dose, which is reduced and then divided into half-half for basal and bolus purposes. You must know that subsequently the doses will work out to be different, and that of course will depend upon very detailed evaluation of the basal and bolus rates, which we will discuss later on when we take up advanced pump therapy. Now the basal rate, as you told, is again calculated as the 50%, and you can either start with a single basal. So suppose you are using about 37 or let's say 37 units a day, you divide by 24 and you give a single type of basal. But as we have been practicing, we have shown that it is possible to introduce right at the outset what we call multiple basal rates, and we'll tell you how those multiple basal rates can be used. So for example, whatever is your total dose, you can frankly introduce 4 basal rates. This is the way at least we practice, because we think that this way you can narrow down on the final doses much faster than you can by the routine methods advocated in the books. And that is, you divide the basal rates into 4 segments during the 24 hours, 4 a.m. to 12 noon, 12 noon to 6 p.m., 6 p.m. to 12 midnight, and 12 midnight to 4 a.m. Remember that the maximum insulin requirement, so the rate will be maximum between 4 a.m. and 12 noon, because this is the period where there is a dawn phenomenon and there is a rise of blood glucose early morning, and the post-breakfast readings also are often high, so this requires maximum doses here. And remember that the minimum doses are between 12 midnight and 4 a.m. And you know very well that this is a very crucial period for watching for hypoglycemia, because 3 a.m. is the commonest time where the hypoglycemia occurs. In between this maximum and minimum, there are 2 other basals used, the 12 noon to 6 p.m. and slightly higher probably between 6 p.m. and 12 midnight, because the pre-dinner and post-dinner blood glucose is also tend to be high in most people. So, or these two may be almost similar, then you will end up with only 3 basal rates, maximum, minimum, and a moderate one in between. There is another way to start, of course. Now, how do you find out the sensitivity of a given individual? Sensitivity is as to how much blood glucose lowering will occur when you inject 1 unit of insulin. So to start with, what you do is you divide 1500 by the pump's total daily dose, see, and whatever figure comes, that you can take as a starting point of sensitivity. As we shall tell you later on in advanced pumping, this sensitivity will have to be tested in every given individual when you are fine-tuning your pump therapy. Also remember that sensitivity is not a constant phenomenon. For example, a same patient can have slightly reduced sensitivity in the morning hours and the sensitivity gets better in the late afternoon or evening hours. So keeping all this in mind, you start with the rule of 1500 divided by the total dose, and whatever figure comes, you see, you can use that. So that will be the amount of blood glucose lowered by 1 unit of insulin injection. If the insulin sensitivity increases, then you will have to have a lower correctional bolus. And if the insulin sensitivity decreases, like I said, in the morning hours, then the correctional dose is larger. So this also can be looked into once a patient goes into advanced education of pump therapy. Remember that we have a basic biorhythm in the body of blood glucose profile, and of course the physical activity will also alter the sensitivity at a given time, and therefore they all will have to be taken into account. Now, how do you evaluate your sensitivity factor? See, you usually evaluate it 3 hours after the last meal, and patients should not eat for 4 hours after the next meal. See, the patient can take correction bolus and monitor every 1 hour for the next 4 hours. This is how you evaluate sensitivity. So you started with some calculations, but you evaluate it by doing this procedure once in a while. Usually in a given patient, the sensitivity may stay reasonably constant for quite some time, unless there is a tremendous change in some of the factors that we will discuss. See, if the target blood glucose is within 30 milligram, it means your sensitivity calculations are correct. So if you are reaching within 30 milligram of your target, means whatever you see you have tried to do, it has worked out, and we call it the acceptable sensitivity factor, that whatever you are using is correct. In case it is off, then obviously you will have to change your sensitivity factor. Now, how do you calculate the meal bolus? The meal bolus is calculated, you see, which is related of course to the food. We know that the total requirement there is again half of the total daily dose. The meal bolus is calculated by again doing the carbohydrate counting. To start with, one what does is divides the 500 by the total dose and takes that as what is called insulin carbohydrate ratio. But you have to evaluate in each patient whether what index you are using as insulin carbohydrate ratio is correct one or it needs to be modified. The main thing required there is carbohydrate counting. So the patients are trained into doing carb counting, and most of them after some time do it with great facility and great ease. The main carbohydrates that you count are of course the starchy foods like cereals and pulses, direct sugar and fiber. The 3 types of things you have to consider. The sources of carbohydrates in food mainly are the bread, pasta, grains, that is rice, wheat, starchy vegetables like these ones, fruits, direct sugar or honey. Milk has lactose in good amount, and that again adds to the carbohydrates, desserts and aerated beverages. These are the ones where the carbohydrates are contained in the total food, and these have to be taken into account when you are doing carb counting. Now, basic carb counting can be done by, you see, what you do is when you do the basic carb counting, you try to see the carbohydrates in each meal. You try to keep the amount of carbohydrate constant, see. Make sure that you read the nutrition labels very carefully in the foods which are packaged. You have to do the blood glucoses frequently in order to judge that your counting has been correct, see. And you have to check for hypoglycemia, and if you find that there is a problem, either you rework the menu or you rework the doses. The advanced carbohydrate counting is a little bit complex. It is important for patients on insulin pump because they adjust their day-to-day boluses at every meal depending upon the carbohydrates that they are going to eat. And it is on this basis they work out insulin carbohydrate ratio, which offers them tremendous flexibility in the type of foods they can eat. As a matter of fact, the control is fully undertaken by the patient, and the locus of empowerment shifts from the physician to the patient once he masters the technique of carbohydrate counting. थोड़ा अभी दूसरा. We utilized two methods of carbohydrate counting. See, and what we do is, one method is you count grams of carbohydrates by using the charts that are easily available in many nutrition books. Other way around, you can use the exchange system where you see how many servings of carbohydrates are contained in a given meal, and then, as you know, the carbohydrate content of one serving is very well known, and therefore you easily get your carbohydrate content. We find that this is easier to use and is reasonably accurate, but this one tends to get more accurate but is slightly more complex, and the patient has to carry with him, or after some time almost memorize some of the common foods and their carbohydrate content. Patient has to keep a meticulous food diary. He has to get familiar with the composition of food, you see, and also he should see his routine meal and carbohydrate content, and there is something extra in the meal, and of course sometimes there is a very complex dish where he cannot figure out the ingredients, then of course the carbohydrate counting will go wrong. Patient has to then match by using this experiment continuously and see with his self blood glucose monitoring as to how, whether he has been correct in the calculation. One, in the calculation, and number two, in using a certain insulin carbohydrate ratio. Whether both of these are correct or not will be finally judged by the blood glucose monitoring, and if they are reaching the target range or they are far off from the target range. The physical activity pattern also will have to be brought in, and as we said, the responses may slightly vary between morning and evening hours. So all this has to be studied by a given patient for his own situation.